Hi, sir.
Hello.
Noah has also joined.
Hello.
Good evening, sir.
Hello, good evening.
Hi, Sumit.
Hi, sir. How are you?
I'm fine.
Good evening, sir.
Good evening.
Yeah, live.
Yeah, welcome everyone. Today to the Squint session 6. Today is an auspicious day, Guru Purnima, and on this I would love to wish our teachers who are here and who are mentors for almost, I think, Squint and Plasty people all over India, Dr. Pradeep Sharma, Dr. Santosh, and Dr. Amitava, and Dr. Sumit. With this, I would like to hand over this to Dr. Pradeep Sharma, who will be introducing our speaker, Dr. Sumit Monga, on his topic, Estimation of Visual Acuity and Refraction in Children.
Thank you, Asha. I think we are once again on to the 6th lecture on Squint and Pediatric Ophthalmology series of iFocus Online. And all the lectures have been very, very well received. They have been very well presented by these previous speakers. Now, today we have a very important topic, that is estimation of visual acuity and refraction in children. And this is something which is really different. If you are a pediatric ophthalmologist, you need to do the visual acuity estimation in a child much differently. And especially if it's a pre-verbal child, it's a totally different ball game than what you are accustomed to doing on the Snellens or the Logmar visual acuity charts. So we have Dr. Sumit, who has a very wide experience. As you can see from this present slide, that he has done residency from MAMC, Farsias, and then several places he has been through LVP, and I think most of the hospitals in Delhi he has been through. And so he has a wide experience to give this presentation, which is really unique and very difficult too. He has had a clinical fellowship at LV Prasad, Hyderabad. He's also a recipient of the Prem Prakash Award for the best Strabismus paper in All India Conference, and AC Agarwal Trophy, and recipient of HS Trihan Trophy also. He has written numerous book chapters. And so we have Dr. Sumit to present to us the estimation of visual acuity in children and refraction. Dr. Sumit.
Thank you, sir. Thank you so much for the kind words. Always blessed to learn from you. So good evening, everyone. And I think I'm really blessed to, present on this auspicious occasion of, Guru Purnima. And I think if we talk about this topic, it's indeed an important one. And I think the message for the postgraduates would be that if you may not like, pediatric ophthalmology immediately, but I think you should be aware of, the concepts of pediatric ophthalmology, so that, any innocent child, when they land up in your ophthalmic practice, whichever specialty you choose to be in, they would be benefited by your guidance either directly or through the appropriate referral that you would want to do. So hence these basics, pediatric ophthalmology are very, very important for us all. So what I intend to do is a quick revision of the visual milestones, which forms the basis of the visual acuity tests in children, and then of course the special methodologies of visual acuity that we have in children, followed by thoughts on refraction using some practical examples, from the clinic. So we know that this is obviously an important thing to assess visual acuity in children, and the simplistic explanation is that the children do have a critical sensitive phase in which the vision is forming, and you really want to catch them young so that you don't have permanent deficits just because you couldn't assess or refract the child, and the child lines with permanent visual deficit. And of course, the methods that you use are much different compared to adults. So a newborn basically sees the world in black and white. The child may actually have a small deviation and is also able to stare at visual targets close to face. By about a month, the child actually can watch the parents more closely, and the tear production also starts by 3 to 4 weeks of life. By 2 to 3 months, the child actually is recognizing the mother's very well, and it's a very strong stimulus for the child to really start the fixation and following. By about 4 to 5 months, the color vision also is kind of developed, probably correlating with the foveal maturation which is taking place, and the child can also stare at some of the visual objects close to the child. And just in the second half of the first year, the infancy, the child actually also is developing the depth perception. Hence, it's important that any misalignment or anything which obstructs the binocularity is really assessed and taken care of. The child can also see fast moving objects at that time. In the second year of life, the child who was at this time was probably just detecting the objects, now is able to recognize familiar objects and pictures in the books, can probably scribble also a little bit. And they say that by around 24 months, the child achieves what we call as 20/20 activity. However, it differs depending on which methodology is used to assess that, as we'll just see in a while. So by around 3 to 6 years, the child can now recognize and recite the alphabets, and is also amenable to some really good recognition acuity tests that we would be wanting to do. So this background actually helps us to understand that in a pre-verbal child, basically the child is actually having resolution acuity, which can be assessed by presenting a visual stimulus, say a greeting to the child, and we observe their movements, either the eyes or the head, and see how well the child can appreciate or detect. And when they lose interest, probably that's the end point where we say that okay, the child is probably not able to resolve this particular thing. Or we can easily do an electrophysiology also, but then it has its own limitations, as we'll see in a while. But these tests may overestimate the visual acuity and may miss the amblyopia in many cases. So these are just rough guides. Then we have the toddler age group, where the child is probably verbal and probably, with improving education, the child may actually be quite literate by around 3 or 4 years only. But then many of the children are not able to recognize, they're only able to match limited shapes and letters by this time. And then we have, the older children who are easily able to cooperate for the standard acuity of types, just an adult after 5 years. So the essentials in pediatric ophthalmology, we need to actually have a pleasant environment, and probably some playful fixation targets in assessing the vision, and a good rapport is essential before we really go forward. So fixation and following is of course a very useful uh, qualitative tool to assess whether the child is really able to see. We do it binocularly first, and then probably can do it monocularly also later. So this is a child who is fixing and following in different directions. And here's a child, a visually inattentive one, who is unable to really fix uh, at targets close to face. So this is also the unfortunate thing that we deal in our clinics. Sometimes it's good to have a narration of the visual acuity. You may not really write in a single letter. You may actually want to write a description that the child is not fixating or following even with the toys or face, and there is a mild photo aversion to the bright indirect ophthalmoscope light. So this kind of narration actually helps the referral doctor to probably assess that what was the situation sometime back. And then we assess the movements of the eyes, but some children do have saccadic dysfunctions, that is they're unable to really move the eyes. So just showing you this again, this was a case of congenital oculomotor apraxia, where the horizontal gaze is defective. And the child is not really following by moving the eyes, but just alternating the head also. And if a child actually has central steady and maintained fixation, meaning that central means the child is actually having central reflex. That means the fovea is fixating. And when you actually cover one of the eyes, the child keeps fixing with the uncovered eye. So that means the child is, having a steady fixation and steady foveal maintenance of the target is being maintained. And the other eye also, if you cover, the child is actually, having steady and is also maintaining. Once you uncover that, occlusion, the child maintains with that eye also. We'll just see this in the next example. So like this child with the strabismus, we cover the left eye, the child maintains, has a central fixation in the right eye. And when we uncover it, the child maintains the fixation with the right eye. So here we'll say the child has CSM fixation with the right eye, but when we cover the right eye, the left eye also fixes. It has a central and steady fixation, but is not able to maintain once you remove the cover. So this is a rough guide, to tell you that probably the left eye may actually have a poor vision compared to the right eye. And when you actually, correct this misalignment by operating and correct the amblyopia also, the child maintains CSM in both the eyes. So again, an example, a child with cataract has central, unsteady and maintained fixation. Once you remove the occlusion also, the child maintains, with the right eye. And when you actually want to cover the right eye, because the left eye has poorer vision, the child would resist occlusion and he's not able to maintain, the fixation from the left eye. And this smiling but ill-fated child with microcornea and coloboma in both the eyes. The right eye is maintaining fixation, a cross fixation actually, which the fixation is not central because of the nystagmus. It's unsteady because of the nystagmus, sorry. It is not central because the macula is involved in the colobomus area, but it's maintained in the right eye. And the left eye, the child resists the occlusion of the right eye. Then we have the electrophysiology where, you have a checkerboard pattern and the child actually, just seeing it, the frequencies are varied. And you basically are testing the integrity of the visual pathway as the light goes to the occipital cortex. And if you actually vary the stimulus, the frequency from, like very high contrast to low contrast over a very short period of time, then you get something called a sweep VEP, a different VEP compared to the pattern VEP normally which we take. And when we draw a chart, then the researchers have found that, the visual potential can, also be found out. The VEP acuity, that is the visual work potential induced acuity, is known to actually really progress very fast compared to, than assessed by other means. But the flip side is, as you know, that it's not just important for the vision stimulus to just go to the occipital cortex, but there is also a lot of post-cortical processing. So sometimes when you have, cerebral visual impairment, the child may actually have a very poor vision, but their VPs may be, very good. So it at best, just gives you a very rough guide, and it's not really helpful to say that, this child actually has a vision or not. Then you have a blind infant. Say, suppose you just spin it around, uh, holding in your arms. Normally, you would have a vestibulo-ocular nystagmus, and there'll be some refixation saccades by a child who would be probably, fixing with the eyes. So if you have wandering eye movements that continue beyond, a desirable level of say few seconds, then the child may actually be blind, and this can be used. Then we have this optokinetic drum, which when presented, from either temporal to nasal or nasal to temporal, in front of anybody's eyes, we have a normal physiological nystagmus. So when you actually present this in front of a child, uh, you would naturally get a nystagmus. And if you really decrease the size of the gratings, the least size which induces this kind of nystagmus can be, help to have some quantified uh, assessment of that. It may indicate a vision, in that child. And generally they say that, if the child is able to really have a cocaine induced nystagmus, he or she has vision of 3 to 5 feet. Now there's a additional development. What is happening is over the past 5-6 years is researchers are trying to really quantify this optokinetic nystagmus by using high sensitive cameras. In fact, we were also part of, one of these studies in association with the Auckland University, where actually we, monitored this cocaine-induced nystagmus, through some special devices. Unfortunately, because of the COVID times, we had to discontinue that. But this is an upcoming field, and cocaine activities again back in fashion. So this is what normally, you would find in literature, that when you chart the different acuities, you would really see that the VP acuity is much faster to develop, possibly because it doesn't depend on the subjective or behavioral response of the child. And the forced preferential looking, which we'll just come to in a moment, just follows that. And the OKN, of course, is the last to really develop. So we have this candy test where you can actually just present some candies, small bead like candies to the child, and if the child can appreciate and pick up those candies, maybe they say a rough quantification of say 6 by 24
the left hand in front of the baby and see that which paddle the baby is looking.
Just
If the child
audio. So basically we have this leaf paddles where we have these kind of gratings, stimuli of dark and light stripes. And when we actually present this grating compared to a blank grating to the child would really want to follow a stripe grating, because that is more kind of desirable stimulus, or more attractive stimulus compared to a blank side. So we do it like this. So we just present two cards, one the blank one and the other with the different stripes, and then the child actually we watch for the child's movements of the eyes. So when the child actually moves to the striped stimulus, we have some readings written on the back of the stripes cards, which tell us that how much the child can really assess. So here it's important to understand the notation of really charting this kind of grading activities. It's cycle per centimeter per degree. So the concept is, I'll just take some time to explain this. The concept is that when we actually have a 1 centimeter visual target, say around 57 centimeters, they've seen that that corroborates to say 1 degree of visual angle. And whatever 1 centimeter has that you can see with 1 visual angle from 57 centimeters. So if you have a cycle of the striped stimulus, say 1 cycle means a pair of a dark and a white stripe. So if you have so many stripes in that particular centimeter of distance, at 50 centimeters, the child would really, see with that. And if the child has vision even beyond that, probably he will be responsive to, stripes which are more finer. And that's how you document the acuity in cycles per centimeter per degree. And similarly, you have this preferential looking test of Teller's acuity, where you have a striped stimulus compared to a dark or a blank card here. And what the tester or examiner does is they just present these kind of cards through the unit, and through a peephole, they're actually looking for the response of the child. If the child actually is seeing this stimulus, they would turn their head to this side the striped side stimulus, and you know that the child is responding to this kind of grating. And the finest grating that the child would be responsive to, or when the child ceases to have any preference to a blank card, that's when we say that, okay, the grading acuity is such. Then we have this Cardiff acuity chart where we have the stimuluses with decreasing contrast as you just go forward. So initially you would want to see the movement of the child, as they see. If the child is actually seeing on the top or at the bottom, you would say, okay, the child is able to analyze that. And as you actually go forward, as we just saw, the stimulus becomes of less contrast. So these are called vanishing optotypes for this reason. And the lowest optotype which the child can actually see with this is the visual acuity of the child. So these adbursts are a rough guide only, and gives a semi quantification of the child's acuity. Initially you do it with binocular, and then you can do it with monocular testing also. Then as the child goes forward in life, becomes a toddler, we have more options that come up. So we have the recognition acuity. That means the child actually, can recognize some of the familiar figures like an apple, or, some of the familiar pictures that the child would have. And the child can have a matching card through which the child can actually tell us that what exactly the child is able to see. Recognition acuity is anyway better than detection acuity, that we had to do in the initial 2 or 3 years, till 2 or 3 years of age. And when the child actually matches the finest figure that you're showing to the child, that's what we say that the child's acuity is. Then the common other matching top types are Sheridan Gardner, HOTV. And note the HOTV alphabets are choosing because there is a vertical asymmetry. And this actually helps the child not to get confused, from the other alphabets which may not have. So it's a symmetric on either side of a vertical line if you draw from this. And then you have this kind of Leah symbol test where you have these 4 symbols which are very commonly known to children: the house, the circle, the apple, and the square. And the child would, just match this, as you keep pointing out to it. So we can have a logmar version of this chart. And this is something, which really helps. So the child matches this, and we can really have a good assessment. And then as the child, of course, goes forward, then we have, this optotype charts that we normally use for adults. And the points to remember is that, the luminance should be very good. It should be a standard luminance, well-lighted chart. And then preferably you should test the binocular vision first, because normally the child doesn't really want anything to be brought close, a cover or anything, in front of the eye. And then always be mindful that many of the children may have latent nystagmus. That means, when you cover one eye, their involuntary movement of the eye may just worsen the visual acuity. So it's better to actually check the binocular vision always first. And if the child actually is having an abnormal head posture, possibly test, with the abnormal head posture in place. You can have an orthoptic examination in forced primary gaze. That means, you correct the posture and then do it. But a visual acuity, you can actually have a good measure in AHP, the abnormal head posture state. Then watch out for peeking behavior. When you cover one eye, if the child has poor vision in the other eye, the child may just peek through in the cover that you're placing, either the fingers. So always, probably use a tissue or a complete occluder to cover and test the vision of the fellow eye. And amblyopes, be wary of the fact that sometimes when you're testing with single optotypes or a single line optotypes, the child may actually respond much more than what you would do on a full crowded, chart. That means there is a crowding phenomena. That means the child actually responds more when we actually present single letter or single line. So this should be known, and an overestimation of the vision should be avoided by separately testing for that. Then, of course, in refraction, we know that it's very important to really have a focused stimulus on the fovea or the retina, so as to avoid the refractive amblyopia, and it really makes all the difference to the child. So this is a acute video actually of a baby who was unresponsive or less responsive, and when we actually just had a +4 diopter spectacle over the child's face, probably the child became responsive, and just on seeing the mother, the child actually just tells all. So this is a 4 diopter test that we should be familiar with, because the children in infancy, they do have hyperopia. So this may actually be one of the tests which can tell us that they may actually have that kind of refractive error even before we test a proper refraction. So a few conglomerated tips. Practice patience, of course, is the key in pediatric ophthalmology in general and refraction in specific. Always retain your art of refracting a child, howsoever busy you may are. It may just come handy anytime. Cycloplegia is mandatory in children. Retinoscopy remains the gold standard, no matter howsoever state of the art uh, devices that we may have in today's era. So clinical skills again have a lot of role in pediatric ophthalmology. So autorefractometer is really an advance, no doubt about that, but really it just helps in refining the axis of astigmatism. Do not rely the spherical components in children just with an autoref. You can always complement that to your retinoscopy findings, but a good retinoscopy is the gold standard anyway. So normally the cycloplegics that we use are atropine, that to an ointment, so that the drops do not really go through the lacrimal pathway and cause less of systemic side effects. Home atropine drops and cyclopentolate. Now, just a word of caution, actually, again, atropine, the usage have become lesser and lesser. Normally, what I reserve in my practice is for children with strabismus, more specifically esotropia, and less than 5 years of age. And I just rule out whether the child has any obvious history like Down syndrome and all, which may be allergic to atropine, any heart disease, any seizure disorder. Again, I just want to avoid atropine in those cases, and always consult the parents, about the possible side effects, about the fever, the flushing of the face. This really helps. Just spending that 2 minutes extra in the OPD, it helps. Homatropine is my drug of choice for most of the pediatric patients. Very, very safe drug. So what I do is generally I combine homatropine with, tropicamide not for cycloplegia, but tropicamide for, having a good dilatation. Because normally I do indirect ophthalmoscopy of the kids also. So homatropine actually gives you a very good cycloplegia, say after 45 minutes of usage, and the tropicamide would complement the dilatation. Cyclopentolate is a very commonly used medication in most of the setups, but personally, actually, in my limited experience, I have seen personally, a lot of neuropsychiatric side effects. Sometimes hallucinations or even precipitation of seizures. So I generally refrain from doing cyclopentolate, but people who are comfortable can actually do that. But my preference is homatropine. So just avoid some common mistakes, that do not hold the lenses too close or too far from the eye. And always, if you do retinoscopy regularly, you would know that if you have fluctuating responses in the retinoscopy, that means your accommodation is not very well, taken care of. So experience teaches you that what's really a good and full cycloplegic effect when it comes. But just keep trying, And of course, the working distance, sometimes, we in an uncooperative child tend to be very close to children, but still you can actually, have an arm's length as a effective guide to really do a refraction. Then occlude the fixing eye in case of strabismus, because you would want to do a central refraction. And in uncooperative refraction, really we need to do retinoscopy under restraint, sedation, under pedicural, or rarely under general anesthesia. In younger children and children with myopia, do not really rely on a subjective endpoint like a PMT test to really uh, give a refractive error. You can actually rely on your refractive findings and experience to give them, the things. We'll just elaborate on this. So Bruckner's reflex is a very useful tool where we are actually just using a direct ophthalmoscope in a little dim illumination to see the red reflex. It not only really rules out any media opacities and the ominous white reflex of retinoblastoma also can be picked up in these cases. And then it has also been used, like in this case, you see a crescent on the top centered at 12 o'clock. So this is known to actually occur in hyperopia, hyperopic astigmatism, and a myopic astigmatism has inferior crescent. So these are, additional helps of Bruckner's reflex. And this concept was used in automated form in form of photo screeners. Now we have a device where just from a distance, you would want to actually, just uh, shine a light in the pupillary area of the child, and the machine picks up the reflex from the backside of the retina, and it analyzes it. And if it gives a reading, where a refractive error is out of range, it will say fail. That means, you have to refer that child. And if it's a pass, so it can be used for a screening. And obviously it needs to be complemented by the retinoscopy whenever you get a chance. Then we did this survey, sometime back, where we just gave some practical examples to the uh, ophthalmologists all over India, and just to share with you some of the experiences. So situation where a 3-year-old child just walks in the OPD, and you have done a good refraction and say the child has plus 1.5 diopters in both the eyes. Now some people actually would want to just call this child again, but let's remember that there's a concept of emetropization where the refractive error is actually going towards the normal in the first few years of life. So there are some numbers which are quite normal for a particular age. So be mindful of those. And this is the chart from the American Academy of Ophthalmology, where they have these cutoffs beyond which only if you have the numbers, then you would want to prescribe. And we also have a similar chart now, 2018 onwards, from the AIOS, the Coimbatore conference, where it was, really given. So these are all available in IGO. You can actually just have a look and give refractive errors only if they are amblyopegenic. That's the concept. Then we have a 4-year-old child who actually had 618 and 612 vision on the vision, and you were having this kind of refractive errors, moderate hyperopia in both the eyes. Somebody called for PMT, and the child is accepting also and improving also marginally in both the eyes. Now, can we actually give the child just on the basis of PMT? Definitely not, because this is the child. On detailed examination, you would want to actually see how is the alignment also. This child actually had esophoria turning into intermittent esotropia, and the child was having preference of the left eye, and the stereo vision also was less. So this was basically a intermittent esotropia because of the competitive esotropia that's occurring. And you would want to really fully correct this refractive error. You don't really want to wait for the PMT result. You would want to actually have a full correction of this child. And suppose the child actually was orthophoric on your orthoptic testing, and the child actually had good binocularity, then only you would have actually probably undercorrected this child, say, by plus 1.5 diopters. And you might actually want to improve the adaptability by using some cyclophysics in the initial phase. So these are all examples to just make you understand that we really require vision, which is basically a subjective test at the end of the day. But then the objective assessment is also important before we decide for the refractive error. And then, of course, for the high hyperops, you may actually want to do that full correction because they are amyloidogenic anyway. So these all things, we need to see. And if we are just dilating, just before doing the orthoptic assessment, we are just missing all this, which we would have otherwise seen. And then another situation, not an uncommon one, where the child just came with just a one-day history that, he was seeing unclear, as they have just joined school after the vacations. And what you discover is that in the undilated state, the child is having, a lot of myopic refractive error. And the child was quite okay, say about a month back. And your cycloplegic refraction surprisingly shows gross disparity, hardly any refractive error. So basically, this child was actually have a spasm of knee reflex. So what it means is that because of the anxiety or other factors, the child's ciliary muscles had a spasm, and because of which the accommodation was overacting, and this lead to a myopic stimulus, a pseudo myopia, which was leading to a lot of myopia and blurred vision. And what you really needed in this case was a good cycloplegic refraction to arrive at a diagnosis. And in the therapeutic thing also, you would need cycloplegia, and you would need transient bifocals in this case, and not really a myopic glass. So another situation where we have a high astigmatism in both the eyes, hyperopic astigmatism in both the eyes, and this child is improving to say 618 in both the eyes. And there are various permutation combinations, which people would want to do. And the crux point here is that astigmatism more than 2 diopters is very amyloidogenic, and children accept high cylindrical errors with quite ease. So do not hesitate to prescribe the full cylindrical powers in younger age, because you are wanting to ward off myopia and not just uh, worry about the adaptation. And spectacle fitting and centration, of course, needs to be really seen. And you would want to really do a pentacam assessment also in these cases to rule out corneal ectasia. And then not so uncommon situation where your refraction has kind of ruled, detected this kind of anisometropia, but the child wouldn't really say anything, he won't really cooperate for the picture charts also that you're trying to, project to him. So what you actually would want to do, so here you would really rely on objective assessment, something called a vertical prism fixation test. So what it means is, so suppose the child is actually almost aligned, a slight exophoria leading to intermittent exotropia, you can say. So just watch. So when I place a base down prism, say 10% diopters over the right eye, the left eye is continuing to fix at a visual target that we are showing from the front. And when we actually place this prism over the left eye, the right eye deviates upwards. That means left eye was a dominant eye, and even beneath the prism, the child is actually fixing with the left eye, and the right eye is actually having lesser vision. So you don't really need a visual test to really, pick up these findings. These are all things which we can actually just do, using these kind of tests. Because if we would have missed this, the child would actually, just have a very dense amblyopia, which is very difficult to get over, later. And then sometimes visions, with associated, other ocular issues, like retinal dystrophy. When you actually have refractive errors, you would want to have a little different approach. You would have to probably correct a little more refractive errors, almost fully correction in this, because the child is anyway, not responding to, any other thing. Then we should all have a working knowledge of, the spectacle frames and lens materials, because just giving the refractive error and leaving it to the optometrist is probably not the right thing, uh, because sometimes the children may actually have a lot of discrepancies in their spectacles, and the desired effect of the glasses to have a proper focus and ward off from myopia may be lost. So we may just detect a very scratched glass or a child looking over the glass, and that may be the cause of the child adopting a head posture, or the child really having a poor vision in spite of all the treatment that you're giving to the child. So always be mindful of these situations. Now, a big debate is there in community ophthalmology circles where uh, the researchers always keep debating between that what should be the ideal thing. We should have a vision screening program or a refractive error screening program to really pick up those myopia cases in the community. So I think both have their relevance, and you cannot actually do without either. So vision screening program, of course, the limitations are that you may not really have a visual acuity cutoff, and the tests that we mentioned, either in the pre-bulbar age group, or in the toddler age group, they do have their own, limitations. So there are no standard tests, that we can say, okay, that probably the child is missing this cutoff, and that's why, the child needs a referral. And it's only really bound to pick up very severe and moderate kind of visual loss, the vision screening. Still, the milder varieties, 6/9, 6/12, may still not be picked up. And probably we need to have a little more standardized vision testing protocols. How much light, how much distance, what is the texture, so all those things, really make a difference in what exactly the vision acuity is. And of course, when you actually are relying on a refractive error screening, photo screeners can do the job. A paramedical personnel can actually, just do that. But again, there may be lot of false positives you may pick up, and which needs to be really, uh, probably, cross-checked with some trained personnel doing the retinoscopies and all, and to organize such a thing, in the mass scale is, of course, very costly also. So the debate continues, but I think the consensus now, which is really at least happening in the pediatric ophthalmology circles, is that at least the vision and refractive error testing should be tested by, say, around 2.5 to 3 years of age. And in fact, when the child joins school, they should really have a mandatory certificate from a qualified ophthalmologist, who routinely sees these, children's. So just to make you, as a parting slide, just to give you a feel of, what it feels like. We just talked about, mute children, but the situation is not really like that. So I have this video clip, with an audio. Just watch it for about a minute, and then we'll just talk about it. क्या बात Right. So, we can just dismiss this, as a crying child, really, being cajoled. But then, we as ophthalmologists saw a lot of things. I'm just playing this in slow motion now. Just watch this. So what we're seeing is that the child is now fixing with the right eye. And now slowly, he'll turn fixation to the other eye. So that illustrates the concept of alternate fixation. There you are, he's fixing with the left eye. So this tells me that, the child is actually having a decent vision in either eye, which is good news. And now I'm just bringing a target, from the child's left side. And what the child is actually doing is the child was actually seeing it from the right eye, indicating that there was some sort of cross fixation, which means good vision from the left, the right eye. And similarly, the child actually cross fixates from the left eye, and that eye also has a good vision. And just in the latter part of the clip, just watch closely. The child actually has a reflex which comes out through the deviated eye, which is basically the Bruckner's reflex. So such amount of information you could really see in that 1 minute, although the child was cranky. So with practice, actually, you can actually, see all these things. So as Professor Sharma and Dr. Ramesh last time illustrated in the presentation, Dr. Sharma's, the short form, the OCIPE, that means observe, confirm. And when we observe these, we confirm that the child actually had a decent vision in both the eyes using the grading acuity. And the inference was that the child actually has infantile esotropia. Then we planned for the surgery and then, executed the plan of aligning the eye. To summarize, we have these age-appropriate visual screening tests, which may be applied. And then we have the concept of the detection and resolution acuity and the electrophysiological tests in the pre-verbal children. Recognition activity with selected matching pictures or the letter charts may be useful in verbal but pre-literate young children. And recognition activity with the optotype may be useful in verbal literate children. Similarly, refractive error screening should also be encouraged in the early age group, say around 2.5 to 3 years. And when you want to prescribe the glasses, not just a subjective response, but a combination of the orthoptic findings and the overall visual need of the child's needs to be kept in mind when prescribing glasses. Thank you so much. Thank you, all the wonderful team led by Professor Sharma. We are blessed to have you all as a part of all of this. Thank you.
Thank you, sir. That was such a wide topic which was covered very effectively. And it's actually very wonderful that you have made such a presentation in such a short time. So we have a few questions for you which are lined up.
I think it's really wonderful to see that comprehensive presentation along with the practical tips which Sumit has presented along with the illustrative videos. So it's really very nice. By the time you get the questions, I think it's wonderful. Yeah, your questions are ready?
Yes, sir. So how do we assess amblyopia in pre-verbal children?
See, again, the issue is that you can have a symmetric amblyopia, or you can have, a amblyopia in one of the eye, monocular or bilateral. So what you would do is that, if you can get a vision to be assessed, followed by objective, tests like fixation behavior, fixation preference, whether the child is really having a fixation preference or not, or a vertical prism fixation test, as I just demonstrated. Sometimes you have a straight-eyed children, and you can't really see whether the child is maintaining fixation in either of the eye or not. So all these things, the vision, and of course, suppose you don't really get a vision assessment at all, for whatever reason. Suppose you just have a refractive error, which you think would be amblyopigenic for the child, and the child is bound to really have an amblyopia. So you come to a conclusion that the child would anyway, be amblyopigenic, but he would let's start the management, whatever we have to, and he would really pick up with time. But, we just do it with the objective means mainly.
Okay. So do you want to add anything in this, Dr. Pradeep, Dr. Amitava?
I think as Sumit has mentioned, there are indirect ways of assessment and the direct assessment of visual acuity. So even if you do not have specialized tests which are required, like what he described, the teller acuity cards or the Cardiff acuity cards, you may do by indirect assessment by seeing the fixation preference test. So in the presence of a squint, as he mentioned, it's very easy. We know that the squinting eye is likely to be emblyopic. You cover the good eye and he would be very, very revolting to when you cover the good eye. But in the absence of a manifest strabismus, you can use the vertical prism that he very nicely showed. So I think these are the indirect ways of assessment, and direct, of course, with the help of teller acuity cards, Cardiff acuity cards. And recently, I think we had presented in the American Academy of Ophthalmology in Chicago 2018, the digital version of teller acuity card that we were trying to develop using the gaze fixing from the Mac computer and using the deep convoluted neural networks, which will assess the visual acuity of the child when he's presented in front of the computer. And these teller acuity cards are the digital form, which will be presented in a sequential form. So if time permits, we can show you actual real time how it is done. So that is one thing which we can assess the visual acuity and know the visual acuity. The central steady maintained fixation, which again Sumit had very nicely shown, is another way of knowing if the visual acuity is equal in both the eyes, which means it's fine. Otherwise, if there is an unequal vision, we can estimate that there must be an amblyopia.
Thank you, sir. Dr. Amitava, do you want to add anything? Sir, you are on mute.
No, I think it's been very well covered. The only thing is that I have now started using app-based visual acuity assessment, and I encourage parents to also do that, because in a crowded, especially with residents around, there's a constant flurry of activity. Sometimes the parents may do a pretty decent job. I'm just looking for a difference in visual acuity, and if parents also get involved, that kind of confirms what we are suspecting in the in a busy clinic. So, and like Sumit has very well pointed out, if you have an amblyogenic cause and you have a poor vision, it's assumed to be amblyopia unless proven otherwise. So obviously you do a cycloplegic refraction, you look at the fundus, you don't get anything organic, you need to assume that you're dealing with amblyopia.
Thank you, sir. Is there any protocol when you do atropine refraction for the children, like punctal occlusion or anything? Do you?
Yeah, actually, generally we, as I mentioned, that we are, whenever we are actually using it, we do the ointment. So when we have the drops, the punctal occlusion can be done, and generally with the ointment and all, it's quite like easy for the parents as well, because it just stays there. And the systemic side effects do come in many of the kids, but if you really counsel the parents well, they are pretty receptive to it. And mind you that if we had the initial refractions, and suppose you are actually wanting to really decide for surgery, for the residual strabismus, partially accommodative esotropia specifically, so at least one atropine refraction is must. So unless and until there is a really contraindication, you definitely want to do that. And one more thing I just want to mention here. Sometimes, very young infant actually comes to us. The child just, parents just say that, the child actually has this esotropia since 2 months. And what we normally do is that we just tell the parents, okay, you come another day with the atropine, but then the patient may actually have come from very far. They may or may not come back to you. So what I do is I definitely see that child then by doing a basic dilatation, so that I don't miss any retinal pathology like retinoblastoma, because the child may not come back to you. You will not give you another opportunity. So you may not really have a very good refraction at that time, but at least have a good view of the fundus, just to make sure that there's nothing else. And of course, you can do a secondary atropine refraction later on in the second. That can be repeated.
So just to add on that, atropine ointment is relatively safe. So instead of drops, but you just need to tell them that use only a rice grain size, because sometimes some enthusiastic mothers may have a full strip of atropine that may cause a toxicity. So many a time what people say that there is an allergy to atropine, it's not allergy, it's mostly a toxicity because of overdosing. So you need to be taking pains to tell them that only a rice grain size, a small half rice grain or just a rice grain size of atropine should be put each time, and which is like twice a day for 3 days. That usually suffices. So I think this is very important to tell the mother, and also tell her specifically that if you put more, there will be fever, there will be rash. Then only it registers in their mind.
Yeah.
Asha, I'd like to add here that last couple of months now, I've started using something I called as sleepy homide. You see, most parents know that when their children wake up, then most children, get up at a particular time, and most moms know about that. So, and I tell them that an hour preceding that, especially if they have somebody locally in Aligarh where I work, an hour before waking up, I tell them to just pull the lower lid, and I demonstrate on my own eye. And in that little space which is created, they just leave one drop in each eye, and they come back 10-15 minutes later, put another drop of homide in each eye, and they come to me by 9 o'clock, and get their refraction done. And we also confirm that there is effective cycloplegia, like Dr. Sumit pointed out. There should be no change in retinoscopic reflex, or even with the Bruckner's, there should be no change, any induced myopia. And it's working so well. In fact, some of my residents who joined some time back, they thought this was an established technique, sleepy homide. And we actually do that. And we now also, we pointedly encourage the mother to bring back that homide with us, so that we can, give it to another parent some other time. So that cuts cost also, and it works pretty well.
Okay.
So which age group you are saying, Dr. Amitava?
So I'm talking about these toddler age groups that come most of the time in my clinic. They are usually these 3 years, 4 years, 5 years old. And they're so naughty and so cranky that I know that my drops are not going to work. They'll end up with systemic side effects, which has often happened, like Dr. Sumita said, with the cyclopentolate. Although we are using now, the students here call it ROP drops. They're using those half-strength cyclopentolate. And but these children are so cranky, they don't allow the drops to stay in the eye. They tear up, it kind of drains off. So I always find out if they have somebody local, an aunt or somewhere where they can stay, or if they are from Aligarh itself, then the sleepy homide seems to do a great job.
So like you have mentioned previously, if you think that some kid is not going to give you another opportunity to examine, sometimes it also happens that it even happens with the refraction also, for the cyclorefraction. Then should we go ahead with the cyclorefraction, like with cyclopentolate or HA, because again HA takes time for the action?
I would say hometropine can be used in that situation when you feel that the child is not going to come back again and you want to do a refraction. In fact, I think several years back in RPC, we had done a study comparing the effect of atropine versus hometropine, which was published in JPOS. And what we found that although it's not a direct relationship in each child, which varies, but it approximately is a 0.75 diopter difference between the atropine cycloplegia and the hometropine cycloplegia. But to have, there would be an individual variation. So we cannot always use, but yeah, roughly about 0.75 diopter difference would be there. So if you do under hometropine, you can then presume that it is going to be a 0.75 diopter more, which you will get with the atropine. So roughly, yes, you can do, but preferably we'll still say that less than 5, use atropine ointment.
Okay. Thank you, sir. How early do we prescribe plus power, minus power, and astigmatism in kids?
Again, I showed you that cutoffs and all. So it depends on that actually. So it's not about, so suppose a child actually has plus 10, say around 6 months, you would want to go ahead, don't wait. So if it is really an amblopigenic stimulus at that particular age, if it is more than 2.5 cylinder astigmatism you're documenting confidently, so better to actually go ahead with that. The child may take its own time, over the next 6 months to really, use that glass. There is always a learning curve, both for parents and the child. But whatever you start today, would be handy later, because whenever you start, it'll be tough. So don't wait for that, the child will grow and then he'll be used to glasses. If the requirement is there and you have documented it, I don't think you should wait. And those cutoffs, roughly guide us.
And generally, we would prefer to use the full correction. I have seen some people giving like lesser doses to make the child adaptive and all. So I think that is only losing time. We should give the full hypermetropic correction, whether it is for accommodative esotropia or whether it is for isoametropic amblyopia. So the other situation is when both the eyes have high refractive errors, and we need to correct it to correct the bilateral amblyopia. Here, I would like to just add one more thing, like what Sumit had presented, the scenario 4, in which there was a situation in which there is a high refractive error in each child. Now, such children, I have seen that alternate patching is being done by many people. It is actually of no use. It's only persecuting the child unnecessarily. You just need to give full correction and no patching unless there is an associated strabismus.
Okay.
So unless there is an associated strabismus or there is an anisometropia, occlusion has no role. You need to just give full correction and that would suffice.
So how many days how much time do you decide that the patching is not working in case of amblyopia?
See, normally that depends exactly what kind of amblyopia it is. Is it anisometropic, strabismic? Strabismic is more denser. It'll take more time. How compliant the child is, so all those things you would want to do that. But personally, what I would say is that if you're actually, if you think that it's not working for a child and the parents are really doing well, and say over 3 to 6 months, you are actually having the same kind of things and all. So sometimes you may actually want to just, consider that, we may not really pursue further. But generally the thing is iso-acuity, that is equalization of vision. And what you're looking for is, like in a, alternate fixation, like in a strabismus case. So equal fixation and the iso-acuity, these are the two parameters. So, but personally, if you ask me practically, all these theoretical things are there, but generally there is some, thing which there is some gap, in the management. Either the child is not actually doing it for so many hours, not able to do it practically, or the child is, doing it and he's speaking through the patch, or he's, really not, the parents are not around. So to give him that benefit of doubt, I do generally really reinforce, at every visit. And, we have innovative ways, like ask them to make a scrapbook of the patches, draw something on it, paste something on it, and, bring it next time for seeing the compliance. Some children are really, really very, very diligent about it. So practically, I would want to continue in the sensitive age group, where the amblyopia is amenable to treatment, even if, it is really not responding for some reason. But generally, in 3 to 6 months, between the two visits, if I'm convinced that the child is doing well and, we had a decent improvement in vision acuity, I can stop also.
Does anyone want to add anything? Or
I don't chase. I mean, like Dr. Sumit again pointed out, if I'm not expecting much improvement, you see the child, even if he from 660 comes up to 624, with a lot of effort, children get very offended. You block their good eye. They can't play around that much. They are at risk of injury. In India, everybody wants their children to do well in school. So, I mean, it's quite a challenge to go forward. And the gain are not registered much on the child or the parent because he's still doing form vision with the better eye. So I have not, I've kind of become a little more conservative about my approach. At one time, my constant refrain was everybody deserves one good effort at anti-amblyopia therapy. But I've kind of, cooled down a bit. And I feel if there is a chance of gain, I do try out. If there is a positive response, great. But if there's not, I explain to the parents, sometimes you give an anisometropic glass, which is heavy on one side, it tends to go on and go down. The eye looks much larger on that side when he's not, say, patch. And it has a lot of issues going on there. And you end up thinking, oh, I've improved a lot by, reaching 624 or even 618. But there is that kind of benefit is not felt by the family or the child for that matter. Mm-hmm. And I also tell my parents that eye is a very good eye, even if it's not seeing very well the form, because it's doing all the safety features of field. So it's not considered a bad eye. I never use the word bad eye for that eye.
Okay. Thank you, sir. In an anisometropia of 2-year-old with -8 in right eye and -1 in left eye, how do we prescribe? Should we take the power difference into consideration?
See, there's something called a Knapp's rule, where what you do is, if you have an axial cause of myopia, so normally we would say, yes, it may cause some kind of anisokenia. Ideally, when the child goes up, we want to shift to contact lenses, which is not possible in a 2-year-old. So what I would do is, I would really give a full correction. Okay. Not worry about the anisokenia, because that's an amblyopic eye anyway. Some kind of amblyopia you would expect. In myopia, you would have less amblyopia because the child continues for fixing for near as such. But a full correction is very well tolerated in these situations. We have a high index class in the -8 side, so that would really look less discrepant between the two eyes. But for sure, I would give full correction, and that works very well. And after some time, when we assess for the amblyopia, and if the child is really having a difference, either objectively or otherwise also, then we'll start the patching also. I don't really start patching in classes the same. That's also one of the things that first you give the child the time to get set with the glasses, and in about 6 weeks, 8 weeks, call the child for amblyopia review. Once you're okay the child has now really been compliant with the glasses, then you actually go for amblyopia assessment and then therapy.
So the optical adaptation for a month, and then we can start the patching. And as long as we are doing patching, the anisoconia is not a real botheration, because one eye is being used at a time. Mm-hmm. So what Dr. Sumita has mentioned specifically, then you can use the high index lenses, which will also reduce the weight, also the thickness of the glasses, and make it more acceptable to the child. So these are the other things which will also reduce the anisoconia, by the way. Then with the high index, the anisoconia is also less. So, but later on, once the amblyopia has been treated, then you can switch on to contact lens if there is a possibility of that.
Thank you, sir. So with this, we will be concluding today's session. Our next session would be on July 15, Friday, on near vision complex accommodation, convergence and pupillary reactions by Dr. Gunjan. So meet you.
Thank you all. Thank you, Sumit, once again. And thank you, Dr. Amitava, Dr. Shefali, Dr. Asha, and Dr. Santosh, of course, for organizing this. Bye-bye.
Bye, sir.
Thank you, everyone.
Thank you for the kind of